Thank you, Dr. Barry, Dr. Samadi, and hopefully we can tag team on top of that case to move forward and work on a concept of making sure that if we're going to measure fractional flow reserve in the cath lab, that we get good data and we utilize it appropriately. Here are my disclosures. They represent a few different companies involved with the coronary physiology arena. I have to leave this on for a second, I guess.
Just go ahead and use the green.
There we go. So, as the previous case pointed out, that fractional flow reserve can be an outstanding tool to aid the operator in the cath lab on the fly, making decisions on how to treat patients appropriately for revascularization or medical therapy or both, but it's only good enough if it's properly acquired, accurately, and properly interpreted. And so we're going to talk about those pitfalls and the specific issues that we encounter in the catheterization lab to make sure that we get good data to make our decisions on. And so Habib showed this a little bit, but we want to kind of get into this in detail, and that is that fractional flow reserve is a derivation of coronary flow, and it's coronary flow of the stenotic artery compared to the coronary flow of the normal artery. Now, how do we get pressure and flow? Well, pressure and flow kind of relate back into the concept of utilizing resistance and pressure and flow. And so the equation really looks like the flow of the stenosis is equal to the pressure of the stenotic artery over the resistance of the stenotic artery. And you can take the same portion for the denominator for the normal artery. We give hyperemia, and Justin will discuss sometimes where we don't have to give hyperemia, but that obliterates the concept of resistance because we minimize resistance down to its lowest common form, and therefore we have flow and pressure being relatively equivalent, and therefore that's how you end up with fractional flow reserve being the division of the stenotic versus the normal pressure, and which is the stenotic pressure is the distal pressure from the wire, and the arterial pressure is the normal pressure. Now, in the complete derivation, as you saw maybe sneakily in Habib's slide, there actually is venous pressure which in there, and that's one of the things you think about in terms of sometimes venous pressure is very high, and we need to account for that when we look at fractional flow reserve measurements. And so keys to a good FFR, we narrowed them down to 4 because time is too short to have a top 10 list. And so number 1 is you need an accurate measure of arterial pressure. Number 2 is you need an accurate measure of distal pressure. Number 3 is, in most cases, you need to completely eliminate resistance. And number 4 is sometimes you need to know when venous pressure is important in making those clinical decisions. And so let's walk through these. With respect to the accurate measurement of pressure, there's technical and mechanical and hemodynamic artifacts that can get in the way of getting accurate pressure measurements. Of course, loose connections, leak in the guiding catheter connections, and improper zeroing of your pressures within the catheterization lab or improper equalization of your guide pressure to your guide catheter pressure, the guide wire pressure versus guide catheter pressure, all will lead to false estimations of your fractional flow reserve. We're going to talk about mechanical, which is usually either a guide catheter related problem or inadequate hyperemia. And then there's hemodynamic artifacts of damp waveforms, of not well flushed guiding catheters, of pressure drift, and the issue of side holes. And so let's walk through a few of these things. Now, when we measure fractional flow reserve in the catheterization lab, we have a guide catheter which sits in the coronary artery, and we have a 14 1,007-inch guide wire with the pressure transducer at the junction between the radial-opaque portion of the wire and the radiolucent portion of the wire. We introduce these and we put these about in the same region of space, whether it's in the aorta or if you get a non-damp pressure signal within the coronary artery, and we equalize these, and therefore the equalization of these pressures should mean that we have a complete duplicate of pressures. We also want to make sure the guide catheter is completely flushed, And therefore, we see a good representation of what we think an arterial pressure signal should look like. We see that depicted down here, where we see a well-described dichrotic notch on each, I guess it's raining, on each pressure. The wire introducer in the back of the TUI or the hemostatic valve can cause a little bit of a pressure difference, and this is an example of this, where you have equalized pressures. Then the wire introducer is introduced into the back of the TUI here, and you see a 3 or 4 millimeter difference in mean pressures as that's introduced into the back, and then as that's taken back out, the pressures re-equalize again. And so true best practice would probably be to remove the wire introducer, to tighten your TUI down so you get no leakage out of the back of it, and then equalize your pressures. Guiding catheter selection and understanding osteal disease and trying to make sure you don't have damping is highly important. And as we see here, and Nico drew these schematic figures a long time ago, but as we increase our guide catheter size, we increase the cross-sectional area of the guiding catheter. And so a 6 French guiding catheter has about a 1.8 millimeter cross-sectional area, and an 8 French guiding catheter has a 2.4 millimeter cross-sectional area. If we compare that to a 3 millimeter artery, you can see that you introduce a greater and greater stenosis from the guide catheter, and therefore you can increase a greater and greater damping of pressure just from the guide catheter. We want to avoid that, and that's part of making sure that we have an accurate and well-subscribed arterial pressure tracing from the guide catheter itself. Here's an example of what you would get if your guide catheter is damped. You would see exactly this. You see an increased pulse pressure, or sometimes we call this ventricularization of the pressure. You see that there's a guide wire pressure that almost matches up with that. So if we equalize those two, we end up equalizing to an inaccurate pressure. If we pull the guide catheter back out of that obstructed osteal segment, you can see a more well-circumscribed arterial pressure tracing with a dichrotic notch, and the distal wire pressure actually does represent distal coronary pressure. And so if we took this pressure as our FFR, we would get a false negative FFR in a highly significant osteal problem. This is a 7 French guiding catheter in the 3 millimeter artery, and you can see that as you introduce the guiding catheter into the artery, you basically create the opposite effect. So I show you what it looked like in pulling out the guide catheter. Now I show you what it looks like if you push the guide catheter in an area of osteal stenosis. And so we have to be very careful in osteal left main and osteal right coronary artery stenoses. Unfortunately, side hole guide catheters don't get around this in any way, shape, or form. And in fact, they introduce even more error. And so here we have 3 different pressures. We have a pressure from a guide wire, which is in blue. We have a pressure from the guide catheter, which is in red. And we have the real arterial pressure, which is in green, which is from a side catheter. And therefore, you see that the green pressure and the red pressure are far from one another, and therefore side hole guiding catheters are not recommended for the performance of fractional flow reserve. There are hemodynamic gremlins which exist in all of our catheterization labs. They have gotten better, they have gotten more tame, but they still exist. When we see pressure ratios that look like this, as we put the pressure wire down the coronary artery, we introduce hyperemia and we measure. We have to always not just take the fractional flow reserve measurement, which exists on the screen, and in this one it would be highly significant. We have to observe the hemodynamic tracings, and in this case we see that the hemodynamic traces look like exactly duplicative, except one is less than the other. You see the dichrotic notch still well circumscribed in the distal pressure, and this in fact is representative of pressure drift. This is not a real pressure difference, but one that was electronically induced. To make sure that you don't have pressure drift, most of us are in the habit of using now intravenous adenosine and doing pullback performances of the wire, pulling back to the guiding catheter, and therefore here is the lesion somewhere down here. You pull the wire back, kind of as Habib showed in his first slide, and as we get back to the guiding catheter, up here we should have equalization of pressures. And in this case, you see that you don't. Your guiding catheter pressure and your wire pressure actually still have a gradient within them. And therefore, if you pull back your wire and you get this, you probably shouldn't take this measurement. You should do it again, because you want to see something like this, where you have a differentiated pressure distal to your lesion, and when you pull back, you have overlapped or completely identical pressures at the tip of the guiding catheter. You can take this number and use it to make your clinical decision making, not the last one. With respect to achieving hyperemia, there's multiple agents that we can utilize to achieve hyperemia. Remember that nitroglycerin does not achieve hyperemia, but adenosine, whether it's given intracoronary or intravenously, are the gold standards for this. And the dose of 140 micrograms per kilogram per minute of IV adenosine is truly the gold standard. It has a little bit of a side effect with respect to its decrease in blood pressure and some burning, and there is a theory in our nuclear labs that it gives you a lot of bronchospasm, although fortunately I've not seen it very much in the cath lab. Now, there's ways to get around this. There's dobutamine that we can give, and that also achieves hyperemia in a 3 to 5 minute time window at somewhere between 30 and 40 mics per kilo per minute, or intracoronary nitroprusside at 0.3 to 0.9 micrograms per kilogram gives a rapid induction of hyperemia if you can tolerate the 20% drop in blood pressure. The A2A analog, regadenosine, or Lexiscan, has also been compared with IV adenosine in 2 different studies, the third of which just got submitted as abstract to a TCT today. I know that because I submitted it. But you see an excellent correlation of the ability to measure fractional flow reserve with a IV push of regadenosine versus an IV infusion of adenosine. Justin's going to talk about whether hyperemia is really necessary, and I'm going to leave him this concept and that to tell you, but there are resting gradients which are probably well subscribed to either defer the lesion or fix the lesion without necessarily giving adenosine or any other hyperemic agent, and so we look forward to Justin's talk. We also have to think about, and the last case forces us to think about the other things that are involved in coronary physiology. Factors responsible for microvascular disease within the coronary bed, which include multiple different things, including diabetes, hypertension, vasculitides, hypertrophy, previous infarction, or vasospasm, as Habib pointed out. There's regulatory which make the measurement of fractional flow reserve relevant and useful in the catheterization lab. I told you I'd talk a little bit about venous pressure. In this study, which was a poster that was presented and subsequently was published, you can see that of about 50 patients, there were 6 patients who had what they called borderline FFRs, and that's the FFR that's in the red, somewhere between the 0.8 to 0.85 range. When they took into account the venous pressure which occurred at hyperemia and the venous pressure at rest, and they put them into the equation of fractional flow reserve, you see that they had mild differences in their fractional flow reserve, but in all 6 of these quote-unquote borderline cases, all of these lesions fell into the hemodynamically significant range. Keep in mind in thinking about the entire patient and when venous pressure may be elevated above when it was in the simple cases of which the validation of FFR versus ischemia testing was performed. And therefore, when we get to the end of the day, when we see tight lesions angiographically, or we see lesions angiographically that are intermediate and we perform FFR, and we get FFRs that are above the ischemic threshold, it's not against the interventionalist creed to provide good medical therapy for these patients. It is part of the interventionalist creed to make sure that the measurement was done properly. Did we go through the right steps? Did we get proper zeroing of the arterial pressure? Did we get proper equalization of the arterial pressure and the guide wire? Did we achieve adequate hyperemia? Did we have a good guide catheter pressure and we were not damped? Did we pull back the wire back to the ostium and make sure that those pressures still matched up after we measured it? Do we repeat it again just to make sure we get the same result? And if all these are true, we should believe it and move on. And these are the steps that I was hoping to leave you with respect to good, proper, and accurate measurement of FFR within the catheterization lab. So thank you very much.